Unit 5, Mental Health Perspective in Chronic Physical Illnesses. 5.1 Introduction. Each individual reacts to physical illness in their unique way. Some overcome it with courage, while others have difficulty overcoming intense emotions like anger, fear, or hopelessness. Various factors affect an individual's response to an illness and its impact on the illness. For example, denial as a response to illness may result in delays in seeking treatment. Medical and paramedical personnel working with patients with chronic physical illnesses should understand their patients' reactions to their illnesses. This understanding can help in planning treatment, modulating patients' behavioral or emotional responses, reducing their distress, and improving their medical outcomes. In this unit, we aim to view illness as a form of stress and explore the individual's psychological, emotional, and behavioral responses to illness. Objectives. After studying this unit, you will be able to learn about chronic physical illnesses, discuss the ways in which chronic illnesses affect individuals mentally and physically, understand the needs, challenges, and limitations experienced by these individuals, learn about psychological factors affecting the response to physical illness, and explore how caregivers may be impacted. 5.2 Definition and Understanding Chronic Illness. The term chronic comes from the Greek word chronos, meaning lasting for a long time. Examples of common chronic illnesses include asthma, epilepsy, cancer, diabetes, heart disease, and chronic fatigue syndrome. The United States National Center for Health Statistics, NCHS, defines a chronic illness as one lasting 3 months or more. The Commission on Chronic Illness, 1956, defines chronic illness as all impairments or deviations from normal which have one or more of the following characteristics, are permanent, leave residual disability, are caused by non-reversible pathological alteration, require special training of the patient for rehabilitation, and or may be expected to require a long period of supervision, observation, or care. Chronic illnesses can begin at any time in life, from childhood to old age, and can create long-term health concerns that require adjustments in normal living. Chronic illnesses may differ in terms of treatment, severity, and prognosis. They may lead to disability, visible, invisible, or static progressive, thereby impairing the quality of life. In the lives of patients, their families, and others who care for them, significant modifications may be needed. For example, the entire family is affected when the primary wage earner becomes the patient. Chronic illnesses may lead to financial, relational, and emotional challenges in addition to physical limitations. Individuals with chronic illnesses may experience loneliness, isolation, embarrassment, fear, and concerns about dependency. Separation from family or friends, whether in the hospital or at home, produces feelings of isolation, disconnection, and stress. Dependency on others for even basic tasks can be very stressful for many individuals. Chronic illnesses require individuals to more permanently alter their self-view. The challenges of chronic illness are ongoing and become an integral part of daily life for these individuals. 5.3 Psychological Response to Illness. Mental disorders are often seen in association with physical illnesses. One explanation for this association is a psychological reaction to the distress imposed by a chronic medical condition, a life-threatening condition, or the overall severity of the illness. Another explanation is that mentally ill patients may perceive themselves as more troubled by medical conditions and therefore tend to seek medical help more often than mentally healthy patients. Studies on illness perception have shown that people who are depressed consider their general and physical health worse than people who are not depressed. It has been observed in medical settings that patients with depression and anxiety rate their physical functioning worse than mentally healthy patients. 5.1 Subjective Variables Influencing an Individual's Response to a Given Illness. The subject of psychological factors affecting medical disorders has become the focus of intense research because interventions at the psychological level have demonstrated improvements in medical outcomes and quality of life for individuals with serious medical disorders. Psychological factors may contribute to the initiation, e.g., psychological stress inducing myocardial ischemia, or the exacerbation of the illness, e.g., noncompliance with treatment. Physicians are adept at identifying immediate physical problems, for example, disabilities caused by cancer, but mental health professionals focus on understanding patients' subjective experiences of illness. They are often asked to evaluate problematic behavioral or emotional reactions to illnesses. An individual's response to illness depends on personality types, coping styles, and defense mechanisms. Interventions for patients and their caregivers can be designed based on their emotional and behavioral responses to chronic illness. 1. Personality types. Most individuals exhibit traits of various personality types. The personality of an individual highlights their adaptive response during periods of stress. For example, a mildly obsessional patient might appear overly rigid, or a dependent individual may seem excessively needy. Extreme expressions of personality traits may aggravate the situation by developing countertransference in doctors and hospital staff, as well as negative expressed emotions in family members. Different personality types have varying effects on responses to physical illnesses. I dependent. Dependent patients continuously seek help, are demanding, and are unable to solve problems or decide among various treatment options. These individuals are more compliant with treatment and prefer to let the physician decide the best course for them. Caring for such patients is difficult for families due to their insatiable needs and greater desire for attention, which may evoke aversion in caregivers. They have limited frustration tolerance, and feelings of abandonment may lead to clinging behavior. Dependent patients benefit from appropriate reassurance that they will be cared for. Limit setting can be achieved by specifying a fixed schedule of visits, e.g., thrice a week, and setting clear expectations regarding the doctor's time and availability. Ka. Obsessional. Individuals with an obsessional personality are meticulous, place a strong emphasis on rationality, and like to feel in control. They focus on details and want to learn all about their medications, diagnoses, tests, etc., often to the extent of missing the broader picture. These patients are easily frustrated by the unpredictability of the hospital environment, such as delays or cancellations of procedures. Illness is perceived as a loss of control over self and emotions, leading to rigid and inflexible behavior when accepting treatment. Providing detailed explanations about their illness and involving them in the decision-making process can help. This approach generates a feeling of control, reduces anxiety, and decreases interpersonal friction. Histrionic. Histrionic patients can be entertaining and seductive, which can sometimes make physicians uncomfortable. They need attention and admiration to avoid anxiety. These patients may fear the loss of attractiveness and experience illness as a threat to their femininity or masculinity. Denial is a common defense mechanism used to avoid anxiety. Encouraging these patients to discuss their fears and balancing warmth with professionalism can be helpful. Paranoid. Paranoid patients are guarded, quick to blame others, and readily feel attacked. They may blame the external world for their condition and are prone to feeling hurt, invaded, or exploited by medical procedures. Stress heightens paranoid traits such as suspiciousness, causing these patients to become more guarded and possibly refuse procedures or tests. They may accuse physicians and provoke defensive countertransference, which can be counterproductive. These patients benefit from being listened to patiently without dispute or agreement. Detailed explanations for treatments are helpful, while confrontation about irrational fears and excessive warmth should be avoided. V. Narcissistic. Narcissistic patients are arrogant, devaluing, and demanding. They often question the knowledge and competence of the treating physician and may request to be seen only by senior doctors, devaluing others they perceive as inferior. They experience illness as a threat to their self-concept of perfection and invulnerability, leading to heightened defenses of grandiosity. Caregivers and staff often comment, "Who does he think he is?" Physicians should avoid taking such behavior personally and instead understand it as an effort to maintain self-esteem. Techniques like allowing the patient to brag or show off can help build rapport. Using phrases such as, "You deserve the best," or "You deserve no less," reassures them and reduces their demands. Schizoid. Schizoid patients are aloof, uninterested in social contact, and often delay treatment until absolutely necessary. Physicians often find it difficult to build rapport or engage these patients in treatment. Illness and hospitalization evoke fear and intense anxiety due to their avoidance of social contact. Physicians should not force treatment or social interactions. Instead, showing interest, building trust, and offering encouragement can reassure these patients that they are safe and will not be intruded upon. That's 2. Coping styles. Problems in coping with chronic illness are common reasons for psychiatric consultation. Patients may respond differently to the diagnosis of a chronic illness depending on their coping abilities. Coping can be problem-focused coping, where thoughts and behaviors are used to alter the problem causing distress. Emotion-focused coping, which involves regulating the emotional response to the problem. Patients tend to choose problem-focused coping strategies when they appraise the situation as being under their control, and emotion-focused coping strategies when they perceive the situation as out of their control. Mental health professionals can encourage patients to adopt more adaptive coping styles. Patients often use trial and error approaches and multiple coping methods during a given stressful situation. 8 types of coping styles have been suggested. I. Confronting, hostile or aggressive efforts to alter a situation. E. Distancing, attempts to mentally detach oneself from a situation. E. Self-controlling, attempts to regulate one's feelings or actions. I. Seeking social support, efforts to seek emotional support or information. V. Accepting responsibility, acknowledgement of a personal role in the problem. VI. Escape avoidance, cognitive or behavioral efforts to escape or avoid the problem. VI. Planned problem solving, careful thought and efforts to alter the situation. VI. Conducting positive reappraisal, efforts to reframe the situation in a positive light. It has been proposed that the choice of coping strategy is partially dependent on the patient's concept of illness as a challenge, enemy, punishment, weakness, relief, irreparable loss, or damage. Viewing illness as a challenge is related to adaptive coping and mental well-being. Viewing illness as an enemy or punishment is associated with maladaptive coping. Coping style can be viewed as either a trait or a process and is often influenced by personality. Patients tend to rely on coping styles they have used in the past, regardless of whether they were effective. Coping styles may change as the nature of the stressor evolves. For example, when a breast cancer diagnosis is made, the patient may initially seek social support, but this may later change to planned problem solving, such as regularly following up for chemotherapy. Coping strategies may have positive or negative outcomes on the illness. Patients who cope well with chronic and disabling illnesses often exhibit a fighting spirit, self-acceptance under all circumstances, the belief that they are more than just their physical body, a problem-solving attitude toward challenges. Factors that may lead to poor coping abilities include previous psychiatric problems, lack of social support, low educational and economic status, severity of the disease at diagnosis, Hanashesh 3, defense mechanisms. Defense mechanisms are automatic psychological processes by which the mind confronts a psychological threat, for example, the fear of death or disability, or a conflict between a wish and reality. Defense mechanisms are usually conceptualized as intrapsychic processes that are largely outside the individual's awareness. A basic understanding of the concept of defense and various defense mechanisms can provide mental health professionals with valuable insight into a patient's emotional or behavioral responses to medical illness. There is some overlap between the concept of coping and that of defenses, but the psychological concept of coping is more behavioral, as it involves action, for example, seeking social support or engaging in productive problem solving, and is generally a conscious experience. Patients often employ different defense mechanisms in various situations or under varying levels of stress. A hierarchy of defense mechanisms is proposed, categorized as psychotic, immature, neurotic, and mature. Psychotic defenses, extreme distortions of reality, typically used by psychotic patients. Immature defenses, common in patients with personality disorders, such as borderline personality disorder. These patients may transmit their shame, impulses, and anxiety to those around them. Neurotic defenses, less noticeable as they distort reality to a smaller degree, are less interpersonal and often involve mental inhibitions. Mature defenses, examples include humor and altruism, which help patients confront stressors such as medical illness and are socially appreciated. Common defense mechanisms. Some of the most frequently observed defense mechanisms in patients are discussed below. I. Denial. Denial of illness is a common reason for psychiatric consultation. Denial is recognized when the patient rejects the diagnosis, minimizes symptoms of the illness, does not seem to appreciate the implications of their condition, avoids or delays medical treatment, appears to have no emotional reaction to the diagnosis or illness. Adaptive aspects of denial. Denial can be helpful in some situations. For example, by rejecting the consequences of illness, such as death, the patient may generate hope, improving their quality of life. Denial of certain emotional reactions, such as fear or hopelessness, can enable the patient to stay motivated throughout their illness. Denial may allow the patient to avoid immediate stress and gradually accept their diagnosis. Maladaptive aspects of denial. Denial may prevent the patient from seeking treatment, which could endanger their health. It can lead to noncompliance after discharge, worsening medical outcomes in conditions like end-stage renal disease and asthma. Denial of medical outcomes, while sometimes beneficial, e.g., in cardiac patients post-myocardial infarction, can have adverse effects if left unchecked. Before diagnosing denial, it is essential to ensure that the patient is fully informed about their illness and treatment. Direct confrontation of denial should be avoided. Instead, a gentle, empathetic, and non-judgmental approach is more effective in reducing negative emotions like anxiety. T. Suppression. Suppression involves the patient consciously putting aside fears about illness and treatment until a later time. These patients may choose to address their fears when they feel ready. Suppression allows patients to accept treatment more easily and face their illnesses with courage. When suppression is active, denial is often considered adaptive. Repression. In repression, the patient is generally unaware of internal experiences, such as fears or wishes, and these thoughts or feelings are not easily accessible to consciousness. Nash 5.4 Psychosocial Adaptation to Chronic Illness. Before discussing the emotional and behavioral responses, let us examine some important concepts of psychosocial adaptation. 5.1 Basic Concepts of Psychosocial Adaptation. The basic concepts of psychosocial adaptation are as follows. 1. Stress. Individuals with chronic illnesses face a greater frequency and severity of stressful situations. Stress significantly affects blood flow to the heart, which may be particularly relevant in patients with pre-existing heart disease. Increased stress is experienced when there is a threat to one's life and well-being. Body integrity, independence, autonomy, familial, social, or vocational roles, future goals and plans, or economic stability. 2. Crisis. The sudden onset of life-threatening diagnoses, e.g. cancer, and disabilities, e.g. spinal cord injury, brain injury, amputation, is highly traumatic. These conditions constitute a psychosocial crisis, disturbing psychological, behavioral, and social equilibrium. The psychological consequences of such crises are long-lasting and may evolve into pathological conditions, such as post-traumatic stress disorder, PTSD. 3. Loss and grief. The mourning process for a lost body part or function after the onset of a chronic illness resembles the grief experienced after the loss of a loved one. Individuals may feel grief and bereavement. Chronicity of the illness serves as a constant reminder that the disease is permanent and thus becomes a source of chronic sorrow. 4. Body image. Body image is defined as the unconscious mental representation or schema of one's own body. It evolves gradually and reflects the interaction between sensory, visual, auditory, kinesthetic, interpersonal, attitudinal, environmental, physical conditions, and temporal factors. Chronic illness can alter or distort body image. Successful adaptation involves integrating physical and sensory changes into a transformed body image, whereas unsuccessful adaptation results in physical and psychiatric symptoms. 5. Self-concept. One's self-concept and self-identity are linked to body image and are often seen as conscious, social derivatives of it. Chronic illness can alter or distort self-concept. The sense of self, i.e. self-identity, may be denied in social interactions with others. who may focus on the person as disabled first, ignoring their true identity. This leads to a diminished sense of the individual's real self. Has 5.4 emotional responses to illness. Individuals suffering from chronic illness may experience emotions such as anger, sadness, fear, frustration, confusion, helplessness, embarrassment, shame, or discomfort. Multiple emotional responses may manifest simultaneously or sequentially. Understanding a patient's personality, coping style, and defense mechanisms can help appreciate their emotional responses. These emotions may impair cognitive functions, causing confusion or an inability to concentrate. States of acute anger or fear may reduce blood flow through already compromised coronary arteries, potentially leading to myocardial ischemia. The heart is particularly sensitive to acute emotional stress, which may explain sudden death during such states. Empathic listening is essential to understanding the patient's predominant emotional response, which can provide clues about the subjective meaning of illness. Emotional responses often carry multiple meanings and can change over the course of the illness. Predominant emotional responses should not be the sole focus, as they may not necessarily be directed toward the illness, but rather toward the physician or another aspect of care. Understanding the underlying reasons for these responses helps improve patient acceptance of the illness and treatment. Educating patients about their illness can help shift their emotional and behavioral responses, evoking relief and hope. Themes underlying emotional responses. According to Richard S. Lazarus's Emotion and Adaptation, 1991, anger, a demeaning offense against self or loved ones. Anxiety, facing an uncertain existential threat. Fright, confronting an immediate, concrete, and overwhelming danger. Guilt, having transgressed a moral imperative. Shame, failing to live up to an ego ideal. Sadness, experiencing an irrevocable loss. Envy, wanting what someone else has. Relief, experiencing a distressing situation that has improved or gone away. Hope, fearing the worst but yearning for better. Happiness, making reasonable progress toward achieving a goal. Detailed emotional responses. 1. Anger. Anger is a common but challenging emotional response, particularly when it leads to maladaptive behavior, such as treatment refusal. Patients with mental or personality disorders are at higher risk. Anger should be understood as a natural response. Empathy, rather than distancing oneself, is key to managing anger effectively. 2. Anxiety and fear. Anxiety is almost universally experienced in medical illnesses. Psychoeducation, empathy, and reassurance addressing specific fears, e.g., death, isolation, disfigurement, dependence, or disability, can provide significant relief. 3. Sadness. Loss of physical function and the inability to perform as before can lead to sadness. Providing an appropriate message of hope by sharing positive outcomes of similar cases can help. Psychiatric intervention with medication or psychotherapy may also be necessary. 4. Guilt. Guilt may arise when individuals perceive their illness as a punishment for real or imagined sins. It can also stem from behaviors contributing to the illness, e.g., smoking, risky sexual behavior. Educating the patient and family while addressing guilt through confrontation can help alleviate this response. 5. Shame. Patients with narcissistic tendencies or those attributing their illness to past behaviors, e.g., smoking-related lung cancer, are particularly prone to shame. This response may lead to avoidance of treatment. Empathy and education are essential to managing this reaction effectively. Hashtag 5.4.3 Behavioral Response to Illness. A patient's response to chronic illness can vary from maladaptive to adaptive. An adaptive response helps both the physician and the patient in managing the illness, while a maladaptive response interferes with treatment. At times, an individual must adapt quickly when diagnosed with a chronic illness because prompt treatment decisions may be necessary, requiring control over emotional distress. A patient's response is influenced by factors such as the type of illness, coping ability, ego strength, the meaning of the chronic illness at that stage, and family and social support. Major concerns often include fear of death, dependency, disfigurement, disability, abandonment, disruptions in relationships, role functioning, and financial stability. Understanding these factors can aid in shifting a patient's response from maladaptive to adaptive. Adaptive responses. Some adaptive responses to chronic illness include I. Support seeking. Patients with a strong social support network benefit greatly during periods of stress. Conversely, low socioeconomic status and poor social support add to psychological risk. Patients may also learn from others suffering from the same illness, helping them feel less alienated. Tie. Altruism. Chronic illness often reduces self-esteem, confidence, and a sense of productivity. Altruistic behavior, defined as selflessness or self-sacrifice for the benefit of others, can help improve mood. Patients might educate others about the illness, raise funds, or participate in community programs related to the illness. This sense of gratification from helping others can be therapeutic. Physicians and psychiatrists should encourage and promote this behavior. Change in life priorities. While chronic illness is rarely beneficial, it can help patients reevaluate their priorities. For example, someone recently diagnosed with a chronic illness might commit to taking medications regularly, adopting a healthier lifestyle, or rejoining religious or community activities. These changes reflect personal transformation, where daily stresses become less significant. IV. Becoming an expert in one's illness. Learning about the illness can give patients a greater sense of control, as managing known fears is often easier than dealing with imagined ones. The patient's personality, coping style, and defense mechanisms influence how this knowledge reduces distress. 2. Maladaptive responses. Some maladaptive responses to chronic illness include I. Non-adherence to medication. Up to 50% of patients fail to adhere to prescribed medication regimens, often without their physician's awareness. Identifying the context of non-adherence can reveal underlying causes, whether persistent or specific to a therapy or general. Psychological factors leading to non-adherence include 1. Defense against stigma. Patients with illnesses like HIV may avoid clinics or stop medication due to stigma. 2. Desire for control. Patients may refuse treatment to counteract feelings of helplessness or to regain a sense of control. 3. Anger. Resentment toward the physician or illness may lead to non-adherence. 4. Mistrust or paranoia. Physicians must build trust through rapport and honest communication. 5. Comorbid psychiatric disorders. Depression may lead to pessimistic views about treatment, while psychosis may impair judgment, resulting in noncompliance. Other factors contributing to non-adherence: cost of treatment, side effects, inconvenient dosing schedules, lack of information, transportation difficulties, conflicting health beliefs. Interventions to improve adherence: 1. Adopt a non-judgmental attitude and directly ask about adherence. 2. Provide psychoeducation to the patient and family about the illness and treatment. 3. Identify and address any psychological or psychiatric issues. 4. Address treatment-related factors such as side effects or cost. 5. Build rapport and maintain a therapeutic alliance. 6. Use positive reinforcement as a motivator. 7. Involve family members to support adherence. Going against medical advice. Patients may sign out against medical advice for various reasons, including anger, fear, frustration, substance cravings, or impatience with discharge plans. They may also believe they are well enough to leave. Preventive interventions: A. Reduce the patient's anger. B. Avoid direct confrontation. C. Diagnose and treat comorbid psychiatric disorders. D. Involve social supports aligned with the treatment plan. E. Provide adequate information about the illness and the need for treatment. F. Assess the patient's capacity to make informed decisions. G. Encourage the patient to return for treatment if they change their mind. Summary of behavioral responses to illness: adaptive responses, I. Support seeking, altruism, reevaluating life priorities, I. Becoming an expert in one's illness, maladaptive responses, non-adherence to medication, going against medical advice. Point 5. Consequences of chronic illness. The major consequences of chronic illness are discussed below. 1. Stigma. Restrictions imposed by chronic illnesses lead to deviations from several societal norms, e.g., utilization of healthcare services, occupational stability. These deviations are often viewed negatively by society, resulting in stigma and discriminatory practices. Such stigmatizing practices increase life stress, reduce self-esteem, and lead to withdrawal from treatment and rehabilitation settings. 2. Disability. Disabilities can be physical, intellectual, or mental health related. A disability may be visible or hidden, permanent or temporary, and may have a minimal or substantial impact on a person's abilities. Chronic illness diminishes the capacity of individuals to respond in satisfactory ways, disrupting the balance between the demands and expectations of a given situation and the individual's ability to meet them. A person with a disability may be unable to perform certain tasks in the same way as others without adaptations. 3. Social isolation. Long-term painful thoughts and emotions can lead to alienation, loss of friends, more symptoms, and feelings of loneliness. 4. Family burden. Chronic illness affects not only those suffering from the disease, but also their family members who care for them. Increased financial, physical, and emotional responsibilities fall on family caregivers. Family-focused grief therapy involves the patient and family meeting together to process events and anticipate the upcoming loss. It often continues for a few sessions after the patient's death, helping the family consolidate positive achievements made while the patient was alive. Counselors may use individual therapy, family therapy, education, and problem-solving programs as interventions for caregivers of patients with chronic illnesses. 5. Impact on children and adolescents. Chronic conditions in childhood and adolescence can affect physical, cognitive, social, and emotional development, with repercussions for siblings and parents. Research indicates that parenting a child with a disability is associated with higher levels of stress. A common consequence of chronic illness and its treatment is short stature and pubertal delay. Undernutrition is common in many chronic conditions, while obesity may result from limited physical activity. Body image issues related to height, weight, pubertal stage, and scarring can contribute to decreased self-esteem and negative self-image, which may persist into adulthood. Children with chronic illnesses are at greater risk of social isolation and educational disadvantage due to school absenteeism and lack of participation in recreational and sporting activities. Young people with chronic conditions experience greater losses in the long term compared to adults. Point 6. Role of caregivers. In collaboration with the family, it is necessary to develop a plan for managing stress. This plan should include the commitment of all family members to address the challenges, draw on past successful coping strategies, reality-oriented approaches. What families can do. Family members may 1. Provide emotional support and containment. 2. Share responsibility for decision-making regarding treatment settings, options, and financial costs. 3. Maintain stability by continuing standard family functions, such as emotional nurturing, feeding, clothing, sheltering, educating, and socializing. 4. Adapt to changes and help the patient cope with the illness. Role of medical staff. Staff providing care to patients with chronic illnesses should understand the psychological responses to illness, behave in an empathetic, non-judgmental, and caring manner, be sensitive to the patient's needs, and address situations where the family may fail to provide adequate care. 5.7. Let us sum up. In this unit, we studied that mental illnesses commonly coexist with chronic physical illnesses. Chronic physical illness has a profound psychological effect on the affected individuals and their families. The psychological response of an individual to illness depends on personality types, such as dependent, obsessional, histrionic, paranoid, narcissistic, or schizoid, coping styles, and defense mechanisms. Interventions for patients and their caregivers can be designed based on their behavioral and emotional responses to chronic illness. Stress, crisis, loss, and grief, body image, and self-concepts are some basic concepts of psychosocial adaptation. It is necessary to have a good understanding of these aspects to assist in alleviating the emotional stresses that chronic illness places on patients and their families, and to ensure maximum compliance with the treatment regimen of the illness. Anger, anxiety, fear, sadness, guilt, and shame are some common emotional responses to illness. A patient's response to chronic illness can range from support-seeking, altruism, and changes in life priorities to becoming an expert in their illness. Alternatively, it may involve maladaptive responses like non-adherence to medication or going against medical advice. Chronic illness has long-term effects on the lives of children and adolescents, often leading to emotional and behavioral problems, emphasizing the need to address these issues at the earliest opportunity. There is a strong need for general practitioners and psychiatrists to understand the role of psychological factors in physical illness and to promote adaptive behavior for better care. 5.8 Glossary. Altruistic behavior. Selflessness or self-sacrifice by an individual for the benefit or sake of others. Body image. Unconscious mental representation or schema of one's own body. Chronic, lasting for a long time. Defense mechanisms, intrapsychic processes that are largely out of the individual's awareness. Emotion-focused coping, regulating the emotional response to a problem. Problem-focused coping, thoughts and behaviors used to alter the problem causing distress. Psychotic defenses, defense mechanisms taken to an extreme degree, often away from reality, and typically employed by psychotic patients.